And next, we're going to move to another component of that quadruple aim we talked about, and that's the individuals themselves, individual patients, and how we think about how to lift them up and really truly make this a patient-centered environment. And we have with us Emily Beauregard, and Emily is the Executive Director of Kentucky Voices for Health, which is a statewide consumer health coalition that works to address the underlying causes of poor health by connecting Kentuckians with opportunities to make change through policy and advocacy. So welcome, Emily, and we look forward to hearing the important perspective from the patient themselves.
Great. Thank you, John. And it's great to be here with everyone today. We can go to the next slide. I think my colleagues have done an excellent job of really laying the foundation here in terms of all of the benefits of an all-payers claims database for Kentuckians broadly, and also for really every stakeholder in our healthcare sector. An all-payers claims database is a really powerful and incredibly valuable tool that we could be using not only to look at cost and ways that we can reduce cost, but most importantly, and as Jenny really emphasized, to look at health equity and how we can improve health outcomes. And in the long run, improving our health is the only way that we're going to reduce costs in our system and to individuals. And so I think that I won't go over all of the ways that, we could use an all-payers claims database to reduce costs, because I think my colleagues have already really accomplished that. But I do want to emphasize some of the ways that these APCDs could both indirectly and directly benefit consumers. I think indirectly, the primary benefit is that we would be informing evidence-based policy and practice, and looking at where our healthcare system is failing, looking at how we can make our health system policies better for consumers in particular, and looking at where the affordability gaps are, and there are many, where there's price variation that just simply isn't fair and isn't based on better services, where there's low value care, where people are receiving services that aren't really helping to improve their health and are possibly even doing harm, and looking at how we can better prevent emergency department visits or hospital admissions or even readmissions. These are ways that we can, at a systemic policy level, make our healthcare system better for consumers. And consumers aren't really, the ones driving those decisions, but having the data from these claims could inform that better policy. I think another way that we could really be using this is for targeted interventions, and going back to health equity, looking at how we can reduce disparities in our system, having demographic data in the system, where you can look at different populations, you can look at different areas of Kentucky, rural areas versus urban, different regions of the state, different health systems, and how they compare, different insurers, and how they compare in their quality and cost and just performance overall. These are ways that we can better spend our money, and looking at, where is that disparity, where is that care gap, and how can we better focus our services in that area, rather than, just sort of a throw it at the wall approach. So that's a way that we could use this for population health, to improve, the health of Kentuckians who are in probably the most underserved areas of our state. And then comparison tools. And I know this is what people immediately jump to when you think of an all-payers claims database. How can we use this? How can consumers use this as a tool to shop and, to make more informed, better decisions with their money? And there's some use cases for that, but they are limited. And that's what I really want to get into more in the next couple of slides. We can go to the next slide. Thank you. So the Healthcare Cost Institute, which I believe Jeff Jeffrey Talbert brought up earlier, is an institute that has done a lot of research into cost. And in 2011, they did a study that looked at all employer-sponsored health insurance spending and found that about 43% of total spending was considered shoppable. So that sounds like, a good deal of spending that we could have a real, impact on if we had some sort of consumer shopping tool. But if you look at that data a little further, you see that about 15% of the total spent on healthcare was actually spent on those shoppable services. And consumers, their out-of-pocket costs only covered about 7% of those shoppable services. So consumers, by and large, are not able to control these services and the cost of services. 7% is essentially in the control of consumers. That was 2011 data. I realize that's about 13 years old now, 12 years. But in 2017, they did another study looking at spending again and found that at that point, 36% of total spending was on shoppable services. So that's actually a decrease, less shoppable services overall. And then separately did an analysis of 70 shoppable services that hospitals must now publish. Starting in 2021, CMS has required that hospitals publish the cost of these services. And they found that about 12% of healthcare spending was on those services, and that totaled about 16% of consumers' out-of-pocket costs. So a higher amount of consumer out-of-pocket costs on those particular services, but still, generally, consumers don't have a lot of control over, the services that they're receiving and what is, the ultimate cost is going to be for those services. So I think we need to keep in mind that, while, and I think someone else mentioned this earlier, that the healthcare system just doesn't act like other sectors. It doesn't act like a free market. And that has a lot to do with benefit design. It has a lot to do with negotiated prices, things that consumers are really not involved in. So we can go to the next slide. I don't want to in any way discourage having this kind of data. So I want to say that up front, I think we just need to know that it will be used more as, Dr. Hoagland mentioned, a way to help patients navigate these costs and these different service options, and a way for providers to better make referrals for high value care. So just keep that in mind as we're talking about, shopping tools. I think having the information is incredibly valuable. I think we need to better understand how we can use the information effectively. And there are a lot of limitations to shopping tools as they exist now and with the data that we have at the present moment. And partly because we're talking about paid claims data, we're not getting the absolute full picture of all of the care that people are receiving and their outcomes. And so while you can get some quality information from this claims data, you don't get that full outcomes picture. And having that Kentucky Health Information Exchange data, which is essentially your medical records combined with an all payers claims database, one day in the future, that would be, really ideal in terms of having that full picture so that we can make those more informed decisions. But at this point, if we're talking about using all payers claims, we need to just understand what that gives us and what it doesn't, so that we can better help consumers navigate those options. And if you look here, I just grabbed a screenshot of Compare Maine, which has a really nice tool for comparing providers. You can see the hospital systems at the top. There are 3 that I'm comparing on the price of an ultrasound. And you see incredible variation there. You also see then, as you go down the list, some quality measures, patient experience, preventing serious complications. And what you see there is that there's not a lot of information. It's really incomplete. So while we have, quality reporting, we have some good data sources, pulling it all together and doing a comparison side by side for provider groups can be really challenging. And I would, really challenge anyone to say that a patient should come to this website, take a look at those 3 prices and make a decision about where to get their care based on that, because what we really want is that high value care, and that may not be the lowest price care. Then again, it could be. We just simply don't have enough information here to make that decision. And I think too, there are some other factors at play here. Even if you see these, price tags as they are, this isn't necessarily the price that the individual is going to pay, because providers negotiate rates with insurers. If you're uninsured, there's typically going to be a sliding fee scale that you may be able to take advantage of. And if you're insured, you're, based on your benefit design and what your particular out-of-pocket costs are going to be, you're going to have to talk to your insurer to determine what price you'll be paying of that amount. So this is a good tool to, broadly get a sense of, what providers are charging, what is out there. If quality data is present, I think it becomes much more valuable and much more useful. But we still have a long way to go in creating a tool that consumers can really use to change the cost of the care that they're receiving, and to do so in a way that they can confidently know that they're getting the best service. And so I think that we want to use this information more so, again, to change policy and for providers to have a better sense of, what services are out there, what the costs are, so that they can better make referrals, and so that, health systems can see what their, competitors are doing, and hopefully everyone will be making improvements both in their cost and quality so that they are attracting patients. But that's a long game. And so I think we just have to start to think about this all payers claims database as one in which we really focus on population health. We focus on, improving policy and practice. And as we get better data and we know that the data is really accurate and consistent, we can start building in these tools that consumers can use directly. I believe that's my last slide. So I'll turn it back over to you, Dr. Langefeld.